Today, I wanted to share with you a presentation that I'm planning to give to physicians that support people of all abilities, talk about healthcare considerations specific to their patients with intellectual and developmental disabilities. You know me, I'm Sharon Spurlock, Senior Director of Family Education at the St. Louis ARC. I've recently celebrated my 35th year here, so I've been involved with people with disabilities and their families in many, many contexts. At the ARC, we organize ourselves under the premise of empowering people with disabilities and their family with the core values of respect, collaboration, and empowerment, really leading us in how we make decisions and how we interact with people. So we want people to be in the center of their lives and that for them and their families to uh, pursue the goals that they have. The way we can help with that is by providing high quality services, family support, and advocacy. And as you can see, one of the things that makes us unique is that we're a lifetime service provider. So we can start working with a family when they recognize that there could be a disability or delay. And we work with individuals with disabilities all the way through their lives till they are in end of life care. I wanted to start off with some Missouri statistics just so you could understand sort of the framework we are supporting people within. So with Missouri, we anticipate that there's 96,900 people based on census data who have disabilities in the state of Missouri, but only 16 of those are receiving paid services. And those paid services vary widely. Only 8,000, which is about 30%, are receiving a comprehensive waiver, which would give them to access things like residential support. So people get a wide range of supports from very small to very large in that 16% on the right side. But on the 64% on the left, those are people that we're not interacting with at all. Maybe those families are figuring out what to do on their own, and the individual is doing great, or maybe they're not doing great and they just don't know how to access services. In Missouri, people of all ages represent the disability population, the largest of which is the adult population at 62%. But we have a significant number of people that are 65 and older now, which is somewhat new in the field of disability. People are living longer, they're getting better health care, and they are getting supports to live healthy, robust lives. The other thing that's significant about that is that only 11% of people are getting out of home services, meaning that they're living in their own home or living in some sort of subsidized supported housing, which means that 87% of people are still living in their family home, some with services, but many, many without services. And so when we look at that, we have to think about that aging caregiver who maybe they're in their 80s supporting a family member who's 60 who has an intellectual disability. That's a dynamic that is, we really have to look at. The numbers are staggering as far as how many families in the United States are living in that situation. So it's imperative that we work with the family to help people get the best possible health care, and also to make sure that their whole family is getting the support they need to live good lives. Because if the family isn't supported, the individual is probably going to falter. Our nursing staff wanted to make sure I shared the difference between skilled nursing and community residential, because when we provide support to people residentially, we are not a medical facility. People are living homes with direct support staff, and those staff may have no background in medical stuff. We have support staff that have high school degrees. We have support staffs that have masters in social work. Very few of them come from the field of healthcare. So when we take people back home, there's only a certain amount of medical support we can provide. We usually have nurses on staff 24/7 on call, and we can do pass nursing duties over with training, but not something like insulin or other kinds of support that require a great deal of oversight from a trained medical professional. It is important to know that most of our staff have gotten a great deal of training about the medical issues that face the individuals they're supporting, about what they need to be looking for, and they're spending a lot of time with that person when they're active. So they're a great resource when they come to the doctor's office to talk to you about what's different now about the way they were acting 6 months ago? What are they noticing about their communication, about their interest in daily activities, about anything else that might be important? So never hesitate to talk to the people that come with our folks, as long as you're directing your conversation to the person with a disability. That's the respectful way to handle that. The other thing we wanted to share is that if somebody's living in residential placement, we may be bound to gather information that's atypical. So we are required to have a significant amount of documentation about why people take medications, when they take medications. Their doctor's orders have to be updated all the time. So just know that that's something that's a requirement for us, and nothing much we can do about that. I wanted to talk about the fact that people with disabilities have a very wide range of communication styles, and verbal communication isn't always their preferred communication style. So, if somebody's coming to you that doesn't have a tremendous amount of verbal communication, they may have other ways that they're communicating. So, they can communicate with gestures, they might use sign language, they may have a augmentative communication device or pictures that they can share information with. But often communication comes out with undesired behaviors, and especially at a doctor's office, it could be anxiety that's reflected in somebody not being able to sit still, or maybe yelling, or having other kinds of issues. So we want to make sure you know that those things, if they happen in the context of a situation that might be problematic, it's probably more about communication than it is about a psychiatric issue. A lot of the people we support have sensory issues. So the lighting in your office, the smells in the office, different sounds that they're going to hear may also be triggering. So we try and provide support so people know what to expect when they're going to the doctor. And finally, people with disabilities have 4 to 10 times more history of trauma and abuse than the general population. So trauma-informed supports of really listening, being aware of things that might be triggering to the person, making sure that they have the time and space they need to be able to process information, are all really, really important things. So when you're working with somebody, you want to speak directly to the patient, as I mentioned earlier. A lot of times our folks have much better receptive communication than expressive. So they may very well understand what it is you're telling them, and be able to process that. It's important, though, that you try and simplify language. And I think that any patient would welcome that you talk to them in the most simple language as possible to help them understand, and give them a couple seconds to process that information. Using visuals is great. So if you have a picture of what that person's treatment looks like, or a picture of what's wrong with their leg, or something going on inside their body, those can be really helpful. And then pay attention again to those verbal and nonverbal communications. I'm not going to share this video here, but you'll be able to listen to two self-advocates talk about their experience with doctors and what they want to see when they go to the doctor's office. If you click on this button when you get this presentation, offer treatment options that are the same as anybody else. We spend a lot of time helping people to learn how to make informed decisions. So it may take them longer to decide which the best option for them, but all the options should be made available. It's very frustrating to me to hear that, for example, one of our local hospitals rules people out for liver transplants if they have autism. What the justification for that could be, I do not know. They have not been willing to talk to me about it, but people with autism are extremely different across the spectrum. So that's not really a good criteria for decision making. And the other thing is to rule out medical issues when people are having behavioral outbursts. Sometimes people don't know how to express pain or other kinds of discomfort they might be having. So it's possible that they're having a behavioral outburst because they have a UTI, because they're having problems with their vision, because they're having seasonal allergies that aren't visibly causing a problem, but they're making them feel uncomfortable. So we try and rule all those out before we address, again, behavior with behavior altering medications. When people are going to the doctor's office, we can help by providing them with some documentation on what their role is and understanding the types of questions and decisions that need to be made, but also who's coming with them and how can they help that person. So it helps to clarify for people what they might need. I talked about visuals before, and I just wanted to share one of the visuals we use with people to help them prepare for a first gynecological appointment. We often see people in adulthood who have never had an experience of going to a gynecologist, and again, they need to have the same treatment options as everybody else. That can be really scary. So we will talk through with them what the room might look like, what the doctors might say to them, how it might feel cold, all those things, so that we can help people prepare themselves. And this has been very effective for a lot of people. People can also bring information to the doctor so that they can let you know in a manner that's best suited for them. Why are they there? What are the things they're worrying about? If there's a question they want to ask, what does that look like for them? And can provide you with some really quick information that's going to be helpful so that you can have a uh, great knowledge about what it is they need in a quick amount of time. And then this is the same type of format for takeaways, because people aren't always independent in managing what needs to happen for them after they see the doctor. This is a way for them to document what needs to be done in follow-up, if there's any changes that need to happen for them. The person or their support staff can fill this out themselves, or the medical professionals can use this. I want to take 1 minute and talk about families, because they are often the center to quality of life for people with disabilities that need extra support, and they know that person's medical history top to bottom. They also know the little nuances that make that person different, and are going to be able to recognize them more quickly. So being able to review the medical history in advance can really help set the tone for a family so that they don't have to reshare their entire medical history about the person every time they go into the doctor's office. Thinking about what the possibilities are, our families have heard over and over again, this means they won't live past 21. This means they'll never walk, they'll never talk, they'll never have a job. And over again, those things have been proved wrong as things change in the world. So making sure we're thinking about positives, again, talking to the patient first, but make space for the family to add some of their information. And then if you have a basic understanding of the resources that are available, that's extra helpful for families. And I'll share a few of those in a minute. So certain disabilities are more likely to have certain medical complications. With cerebral palsy, obviously because of muscle spasms, there's going to be a likelihood of pain, a likelihood that there's going to be issues with mobility and being able to maintain physical muscle mass and flexibility is really, really important from a preventative standpoint. People with cerebral palsy may or may not have an intellectual disability. I think that's important to know, that because somebody's speech is slurred, it might be more about the muscles in their face versus their cognitive ability. So people may not have any cognitive challenge, but often they have processing challenges where maybe it takes a little bit longer for them to think about what you said and respond. And I won't go through every one of these, but those are things that we think about a lot. Also, potential GI issues are pretty common for people with cerebral palsy. Autism, GI issues again. I think autism is connected to anxiety quite a bit, and so all of that comes together. The GI issues also impact diet and nutrition, and there's sensory issues that can mesh up with that as well, so it becomes problematic. Sleep can be really challenging for people with autism, and so building a really healthy sleep schedule is really, really important. ADHD is very common, and interestingly, Down syndrome is the combination of Down syndrome and autism is more prevalent than with other disabilities. And then with Down syndrome, a lot of folks with Down syndrome have heart defects, again, GI defects. They might have an immune disorder or sleep apnea, struggles with obesity. And then I think most of you know that dementia is more likely with people with disabilities or with Down syndrome. This is a picture of Dr. Ansus, who is a local expert who's running a national study on Down syndrome and dementia, and helping to develop new medications that address the amyloid buildup that people with Down syndrome have in their brains. Yeah, this is just a snapshot of where people go for support. Our Missouri Department of Mental Health is the primary funder in the state of Missouri for people over 3 with disabilities. And Missouri First Steps, it's part of the Department of Elementary and Secondary Ed, is for very young children. There are family support resources, many of those. FACT is a family advocacy group. And then Missouri Guardianship. One thing I want to talk about before we leave today is that families are often influenced by doctors that when their family member with a disability is turning 18, that they seek out guardianship. And there's many levels of decision-making support for people with disabilities. So we encourage people to look at that broad array of options rather than jumping into legal guardianship, because that can be very hard to reverse. And a lot of times, all people really need are good advisors to help them make really good decisions. So, and then, of course, if people have issues with basic needs, they can talk to our family support teams and also use United Way 211.